وإن شاء الله هنبدأ السيشن الأندرولوجي. هيشرفنا بداية الدكتور عمرو المليجي، هيكلمنا عن تستوستيرون ريبليسمنت ثيرابي. اتفضل بيه.
First, I would like to thank Chairman Armeni and all young staff for giving me this opportunity to come here and lecture among you. I'm very honored to have Dr. Hamid and Dr. Asad as my chairmen, and to have my colleagues here around me today. I excused my colleagues that I will start, though I should have been at the end of the lecturers, because I have an aeroplane to catch after that. Now, speaking about testosterone replacement therapy for a specific category, for the infertile males, for those who want to fatherhood, to conceive. Now, في حاجة نقلب بيها لو سمحت ولا من هنا؟ right ولا left؟ ده كده؟ okay. During the journey of life, you all have choices to make. And sometimes it's very tough, some of these choices. It reminds me of this famous film, Sophie's Choice, for the Academy Award winner, Meryl Streep, who had to choose between giving one of her siblings, whether her daughter or her son. I'm just comparing it to tell you that sometimes the man has to choose between leading an enjoyable sexual life or fathering a child. And this is my multiple choice question for you, okay? Dr. Hisham told me to start with a multiple choice question. Now, if a man is to choose one or two or both, I think all men will go that they need both. So how to do that for these men who are deficient in testosterone? Now, with time, there is increased sensitivity of testosterone to the hypothalamus and the pituitary, resulting in reduction of the LH, RH, and LH. This will lead to reduction in testosterone and increase in the sex hormone binding globulin. We'll see that with time we have between age of 40 to 49, you see that you lose about maybe 5 to 10% of your testosterone level, and reaching above the age of 60, about 25% of the testosterone is lost. Do you have a pointer here, please? No? Okay. This is a study, a HIM study, which is well known. It was done on 2,000 patients, and it has shown that above the age of 45, about 38% of men can suffer from symptoms of hypogonadism. Hypogonadism results in a lot of symptoms that irritate the man, like loss of libido, loss of vigor, obesity, particularly visceral obesity, which results in diabetes, it can result in the metabolic syndrome, dyslipidemia, diabetes type 2, feeling depressed, erectile dysfunction, hot flushes, and so forth. And it's also increased all kinds of mortality is associated with hypogonadism. And that are the reasons why we treat these patients, in order to improve their sexual function, whether it is libido or erectile dysfunction, the metabolic disorders, osteoporosis, dyslipidemia, or diabetes type 2, the psychological issues like the mood disturbance and the reduced well-being and quality of life. طيب شكرا
برايت ليفت بقى
من هنا بيقلب برضه؟ طيب جميل. Treatment of hypogonadism typically includes testosterone replacement therapy, and this results in satisfactory amelioration of symptoms and the serum testosterone. However, treatment with exogenous testosterone will result in decrease in the gonadotropin release, and this impairs spermatogenesis and suppresses intratesticular testosterone. If we see that the normal serum testosterone is roughly about 14 moles per liter, while the intratesticular testosterone is about above 1,000 nanomole per liter. So we see how much the testosterone that we actually need for spermatogenesis. And administering exogenous testosterone will result in reduction of FSH and LH, and ultimately result in severe oligospermia or azoospermia. In spite of that, unfortunately, we still see physicians prescribing testosterone as an infertility treatment. Also, there is the abuse of anabolic steroids in order to increase the muscle bulk, which is practiced a lot in gyms and in clubs right now, and this is actually to be condemned, these kinds of procedures. Treatment of hypogonadal men desiring to reproduce while on TRT remains a challenge. Now, currently, the medical treatment that we use for hypogonadism, for male hypogonadism, includes clomiphene citrate, aromatase inhibitors like anastrozole, and exogenous testosterone. However, only exogenous testosterone is the one that is approved for treating hypogonadism. Clomiphene citrate, as you all know, is a selective estrogen receptor modulator, which is effective to increase testosterone. And anastrozole is a potent aromatase inhibitor, which increases serum testosterone while decreasing estradiol production. In general, there has been sub-studies which have tried to use clomiphene citrate to increase testosterone and to treat hypogonadism. And there has been studies since the 90s, and it has proved that it can result in increase in serum testosterone and to treat patients with symptoms related to hypogonadism. This is a study which they were trying to compare clomiphene citrate with the use of a transdermal kind of testosterone, and it was found that there was an increase in the testosterone with about 100. It's not working. It can result in an increase in the testosterone with about 100% with the clomiphene citrate and about 150% with the transdermal testosterone, which was statistically significant difference between the baseline and the increase in the testosterone levels. And there is something called the Adam questionnaire, which is the way that we can see a score for the hypogonadal symptoms, and it was statistically improved with clomiphene citrate on the overall level and on the sexual function domain. However, there was a report, that the clomiphene citrate might not be as good among different ages. In the older population, there was, in this study, which was of a limited group of patients, there was a limited stimulation of the testosterone production if compared to a younger population. Recently, there has been another drug in the pipeline right now. It's still not approved. It is named the androxal, which is in clomiphene. It's a single isomer of clomiphene citrate. And the preliminary report shows that androxal at doses 12.5 and 25 increased testosterone level significantly and was well tolerated and safe and can restore testicular function. This therapy addresses the majority of men with low testosterone, and the company which has made this drug thinks that they can bypass the obstacles that they had with clomiphene citrate, which when it was admitted for approval for the treatment of hypogonadal men. This is one of the studies which have been performed comparing oral N-clomiphene citrate with transdermal testosterone production, and it has shown that both. Now, the N-clomiphene citrate is the green curve, while the transdermal testosterone is the red curve, and we can see that both resulted in increase in the testosterone level. However, when we go to the sperm production, is what is it was increased the sperm production with the N-clomiphene, while it was decreased if we go with the transdermal testosterone. Similarly, with LH and FSH stimulated by the N-clomiphene, suppressed by the testosterone gel, and there was no consistent effect on sex hormone binding globulin, and there was a decrease in the insulin growth factor with the N-clomiphene, and this was not known why and what is the significance for it. Secondly, there was the trial to use low-dose human chorionic gonadotropin. It was a study which they tried, first they suppressed the testosterone production by giving testosterone injections, and then they started to combine it with low doses of human chorionic gonadotropin given subcutaneously every other day, and they found that the best dosage was the 500 international units, which restored the testicular function if given in combination with the kind of testosterone, whether it was in that study testosterone enanthate injections or the testosterone gel or transdermal testosterone. This is a study also which they were given testosterone preparation plus 500 international units human chorionic gonadotropin every other day, and they compared the semen parameters before and 1 year later, and they followed up the patients. And they found that there was no difference in the semen parameters during this 1 year of follow-up. There was no impact on semen parameters as a function of testosterone formulation. No patient became azoospermic with the concomitant treatment, and 9 of the 26 men contributed to pregnancy with the partner during follow-up. This is the latest recommendation for treating from the AAU in 2013 for treating the hypogonadal men who are desiring to be fathers, is by giving human chorionic gonadotropin 1,500 or to 5,000 administered intramuscularly or subcutaneously twice weekly, and in cases with secondary hypogonadism to add FSH together. However, they put a limitation that since we do not know for prolonged use what are the side effects, okay, and what are the effectiveness of giving this regimen to patients for a long duration, they only limited it to patients for the duration that they want to father children. During that period, sufferers of low testosterone can be given this regimen. Our conclusion and take-home message that hypogonadism, as we said, is not uncommon, particularly above the age of 45. Hypogonadism can lead to symptoms, whether sexual, like decreased libido or erectile dysfunction, can lead to metabolic disorders like dyslipidemia, impaired glucose metabolism, can lead to psychological problems like mood disturbance and reduced well-being. Testosterone replacement therapy results in satisfactory amelioration of symptoms and normalization of the testosterone. Treatment with exogenous testosterone decreases serum gonadotropins, impaired normal spermatogenesis, and suppresses intratesticular testosterone. Clomiphene citrate, anastrozole can be an alternative in such a case, or low-dose human chorionic gonadotropin together with testosterone replacement therapy can preserve the fertility potential for these men. And just the last slide, never forget that when you are treating an old man suffering from hypogonadism, that he can want to become a father. Thank you very much.
Thanks, Dr. Amr, about this excellent talk.